Hey everyone, and welcome back to Breaking Down Nursing. Today we're going to focus on the top 20 medications every nursing student must know. So let's dive in. Our first is metoprolol, also named Lopressor or Toprolol XL. Metoprolol is a beta-1 selective beta blocker. It works by blocking the beta receptors in the heart. This results in decreased heart rate and contractility and reduced cardiac workload, also lowering blood pressure. We use it in things like hypertension, angina, chest pain, AFib, heart failure, and post-MI. Things we need to remember to assess is blood pressure. Generally speaking, we hold it if systolic blood pressure is less than 90. Hold if heart rate is less than 60. Always remember beta blockers end in LOL, or LOL. Next up is lisinopril. Lisinopril is an ACE inhibitor. Remember back in anatomy when you learned about the RAS system? ACE inhibitors directly affect the RAS system. They work on inhibiting conversion of angiotensin 1 to angiotensin 2. This results in vasodilation, drops blood pressure, and reduces heart workload. Uses include things like hypertension, heart failure. Assessment includes blood pressure. Again, we'll hold if systolic blood pressure is less than 90. And of course, for ACE inhibitors, we need to watch for a dry cough. ACE inhibitors can cause an increase in bradykinins, which can lead to angioedema, which leads to a medical emergency. So watch carefully for angioedema and dry cough. It also can cause hyperkalemia and dizziness. So pearls to remember, ACE inhibitors end in pril. We also need to monitor labs like potassium, and of course, avoid potassium supplements as it can cause hyperkalemia. That also includes salt substitutes, which can be high in potassium as well. Next up is losartan, which is an ARB. ARBs also work in the RAS system, just in a different location. ARBs block angiotensin 2 receptors, which also result in vasodilation, drop in blood pressure. Very similar effects to ACE inhibitors. We use it in things like hypertension, heart failure, and ventricular hypertrophy. We also need to assess for blood pressure and hold if systolic blood pressure is less than 90. It can also cause hyperkalemia and dizziness. And pearls to remember for ARBs is they end in sartan. Generally speaking, we start patients on ACE inhibitors, and if they're unable to take them, we switch them to ARBs. Big key point is we don't want to take them together. Both of them work directly on the RAS system and can cause problems if both of them are taken together. Next up is furosemide or Lasix. Furosemide is a loop diuretic. It acts directly in the nephron on the loop of Henle and promotes excretion of sodium, water, and potassium. Furosemide is used for heart failure, pulmonary edema, fluid overload, especially in emergencies, because it works so quickly. We'd want to assess for blood pressure and hold if systolic blood pressure is less than 90, and also for hypokalemia, as we can lose a lot of potassium when we're diuresing a patient. Make sure to monitor for edema, eyes and nose, and daily weights to see if it's effectively working. Pearls to remember for furosemide: monitor for ototoxicity. This is one of the meds that we don't want to rapidly push. Monitor for hypokalemia, dehydration, and of course orthostatic hypotension. So make sure your patients get up slowly. Next up is spironolactone. This is a potassium-sparing diuretic. It works by blocking aldosterone, resulting in fluid loss while retaining potassium. We use it in things like heart failure, hypertension, fluid retention. Now, what's the big difference between spironolactone and furosemide? Spironolactone is not as rapid a diuretic as furosemide. Furosemide works much faster, and we use it in emergency situations. Make sure to assess for blood pressure, hyperkalemia, edema, eyes and nose, and daily weights. Remember, this is a potassium-sparing, so some pearls for spironolactone or monitor for hyperkalemia. Of course, dehydration, orthostatic hypotension, and avoid salt substitutes, which can have hidden potassium in it. Next up is digoxin. This is a cardiac glycoside. It increases cardiac contractility, resulting in the heart pumping stronger and more effectively. Our uses are things like heart failure, AFib. Make sure to check an apical pulse for 1 full minute prior to giving digoxin, and hold if heart rate's less than 60. Many times we're giving this to AFib patients, and with the irregularity of the heart rate, we need to assess for a full minute. Also, make sure to monitor for signs of toxicity. We have a very narrow therapeutic window for digoxin, and signs of toxicity could include things like nausea, vomiting, yellow-green halos, and bradycardia. This is a highly tested subject on the NCLEX. Make sure to also monitor your labs, including digoxin potassium levels. And our pearl to remember is hypokalemia can increase the risk for dig toxicity. Next up is nitroglycerin. This is a nitrate vasodilator. It works by dilating the coronary arteries and veins, resulting in decreasing cardiac workload. We use this in things like angina, chest pain, MIs, pulmonary edema. We need to assess prior to administration for blood pressure. hold a BP is less than 90. Of course, if we use it topically, it can cause headache, flushing, and hypotension. Remember also, some pearls, we want to store the sublingual tablets in the original dark container. We don't want to give nitroglycerin to patients who have had a phosphodiesterase inhibitor within the last 24 to 48 hours. This would be things like Viagra, Cialis for restless leg syndrome. This could lead to dangerous hypotension. Next up is heparin, an anticoagulant. It works by preventing clot formation or clot size increase. Its uses include things like thrombosis, embolisms, AFib, DIC, DVT prophylaxis, depending on whether it's sub-Q or IV. We want to assess for bleeding, as this is an anticoagulant, and we'll monitor and titrate the heparin drip if it's IV by using the lab APTT. The way I always remember it is the two T's look like an H for heparin. Some pearls to remember: the antidote is protamine sulfate. Also keep in mind this prevents new clot formation or the clot getting bigger in size, but does not dissolve the existing clot. It just buys us time to allow the body to break down the clot itself. Patient education includes things like bleeding precautions, like using a mechanical razor instead of a straight blade. Next up is warfarin or Coumadin. This is also an anticoagulant. It works by also preventing clot formation or increasing clot size. Some uses include thrombosis, embolism, AFib. We don't use warfarin for prophylaxis. Generally speaking, if somebody comes into the hospital, that's where we would use heparin sub-Q. Warfarin allows patients to be able to go home and not have to be on an IV drip. So keep in mind, we'd want to assess for things like bleeding. The lab to monitor for warfarin therapeutic range is INR. We'd do a Coumadin bridge if patients were transitioning off heparin or Lovenox to be able to go home on warfarin. This is about a 5-day therapy window where they would utilize both medications until they became therapeutic on warfarin, and then we would take them off either their heparin or their Lovenox. The antidote for warfarin is vitamin K. This also does not dissolve existing clots. It just prevents new clots from forming. Patient education includes bleeding precautions just like heparin or other anticoagulants. And of course, we need to educate patients on consistent vitamin K intake. Next up is our insulins. Here we have a breakdown of the insulin types with the onset, peak, and durations. Rapid acting, like Lispro, Aspart, are quick onset, quick offset. We typically use these types of insulins for things like sliding scale insulin. We also have short acting insulin, which could last up to 10 to 12 hours. Things like regular insulin. We also have NPH, which is an intermediate acting insulin that can last up to 18 to 20 hours. And of course, our long acting, which as you notice does not have a peak, just has a basal rate for up to 24 hours. Assessment includes monitoring for blood glucose. Anytime we give insulin, we always need to monitor for hypoglycemia. This would include things like sweating, tremors, confusion, and tachycardia. As a side note, if your patient's taking a beta blocker, they may not be able to show signs of tachycardia, as beta blockers can blunt or hide signs of hypoglycemia. Some pearls also include regular insulin is the only insulin commonly administered IV. Next up is metformin. Metformin is in the biguanide class. It reduces hepatic glucose production, improving insulin sensitivity. We use it for things like type 2 diabetics. It also has an off-label use for PCOS. Make sure to always assess blood glucose and of course monitor hemoglobin A1C, which is a 3-month overall average of glucose. Some pearls for metformin include lactic acidosis. Whenever a patient's receiving contrast dye studies, we want to hold metformin before and 48 hours after, as this could result in increasing the likelihood of patient going into lactic acidosis. Next up is levothyroxine. Levothyroxine is a hormone or thyroid agent. It's synthetic thyroxine, which is T4. We use this to replace missing thyroid hormone. This increases energy levels and body temperature. Its uses are for hypothyroidism. We need to monitor TSH levels as we're giving a medication to increase thyroid. We'd also want to make sure that the patient doesn't go into hyperthyroidism. Some signs and symptoms would include tachycardia, hypertension, chest pain. Pearls include making sure to take in the morning on an empty stomach. It could take several weeks to be effective as they find the correct dose for the patient. And do not take with calcium, iron, or antacids, as it decreases the ability to absorb the medication. Next up is albuterol. This is a short-acting beta-2 agonist and relaxes the bronchial smooth muscle. Now keep in mind that we also have beta-1. The way I always like to keep them separated is beta-1, we have one heart. Beta-1 affects the heart, but we have 2 lungs. Beta-2 directly affects the lungs. Uses indicate asthma, COPD. We assess things like breath sounds, respiratory rate, O2 saturations, blood pressure, heart rate. Some pearls include that albuterol is a rescue inhaler. It's for immediate relief only. This would not be used for a maintenance inhaler. Some side effects of albuterol include tremors, tachycardia, nervousness, and of course we need to monitor for hypokalemia. Next up is prednisone, or a corticosteroid. It suppresses the immune system and decreases the inflammatory response. Uses include things like inflammation, asthma, autoimmune disease, allergic reaction. We'd want to assess and monitor blood glucose, fluid retention, hypokalemia, and signs of infection. For chronic users of steroids, we don't want to stop abruptly, and we always want to make sure that we taper off slowly, as long-term use can suppress adrenal function. Make sure to take with food to decrease the risk for GI upset, and this also increases the risk for infection. Next up is vancomycin. Vancomycin is a glycopeptide antibiotic. How does it work? Well, it inhibits bacterial cell wall synthesis, making it bactericidal. We use it mostly for gram-positive organisms. So what are the uses? MRSA infections, soft tissue infections, endocarditis, osteomyelitis, and if taken orally, it could be used to treat C. diff along with Flagyl. What do we assess? We need to monitor trough levels, kidney function, and it has a high risk for ototoxicity. So some pearls, if we infuse it too fast, we can cause red man syndrome. So make sure to infuse slowly over the time frame allotted by the pharmacy. Moving on to gentamicin, which is an aminoglycoside. It works by inhibiting protein synthesis or bactericidal antibiotic, and we use it mainly on gram-negative organisms. Uses include things like sepsis, complicated UTI, intra-abdominal infections, endocarditis, and pseudomonas. Gentamicin also has trough levels we need to monitor closely because it can affect kidney function, urine output, and ototoxicity risks. Next up is Protonix, a PPI, or proton pump inhibitor. It works by blocking the proton pumps in the stomach, thereby reducing gastric acid production. We use it in things like GERD, peptic ulcer disease, gastritis, stress ulcer prophylaxis, like patients that are in the ICU or under extreme stress. We need to monitor for abdominal pain, specifically GI bleeding. We need to watch MAG levels if taken for prolonged periods of time. And of course, diarrhea. It increases our risk for C. diff. Make sure to take before meals. And again, long-term use can increase the risk for fractures, C. diff, and hypomagnesium. Next up is ondansetron, or Zofran. It's an antiemetic. It's a 5-HT3 receptor antagonist. It works by blocking serotonin that triggers the vomiting reflex. We use this a lot in nausea and vomiting patients, anywhere from post-op nausea and vomiting to even chemo-induced nausea and vomiting, or unknown reasons for nausea and vomiting until we find out the reason. We need to monitor for bowel function through EKG, as the medication can cause QT prolongation to have an increased risk of torsades. We want to use cautiously in patients who already have cardiac dysrhythmias or other QT prolongation medications. Next up is morphine, an opioid analgesic. It binds to the opioid receptors in the CNS, altering perceptions and response to pain. We use this anywhere from moderate to severe pain. It comes in oral to IV. We can use it in acute MIs, cancer pain, post-op pain, palliative care, and in pulmonary edema, as it decreases the risk for air hunger. Assessment includes monitoring respiratory rate, as it can cause respiratory depression, O2 saturations, blood pressure, level of consciousness, and bowel function. Too much of any narcotic can cause opioid-induced ileuses. And of course, keep Narcan available at all times. Morphine can also cause hypotension. Need to monitor blood pressure. Next up is naloxone, or Narcan. It's an opioid antagonist. It competitively binds to opioid receptors, displacing opioids from receptor sites. We use this for opioid overdoses, opioid-induced respiratory distress, and reversal of opioid effects. Of course, you need to monitor for respiratory rate, O2 sat, level of consciousness, heart rate, BP, and opioid withdrawal. The med duration lasts about 30 to 90 minutes, so there may be a potential that patients may require a repeat dose, and we need to monitor closely. Thanks for watching. If you found this video helpful, be sure to like, subscribe, and hit the notification bell so you don't miss future content. If you're a nursing student looking for study guides, practice questions, NCLEX tips, and a community of students working toward the same goal, check out the Scrub Circle in school. It's a great place to connect, ask questions, access resources designed to help you succeed in nursing school and beyond. Let me know what topics you'd like to see covered next by leaving a comment below. And as always, take care and see you next time.